Hello there. Can you hear me? Can you hear me?
I can.
Super. This is Ian Muchamore here. I'm part of the PHAA Mental Health SIG, that's the Special Interest Group. Today's webinar is on work as a social determinant of mental health and well-being. And I've got with me in his office at Deakin University, Professor Tony LaMontagne, who I've known for several years. Let me tell you a little bit about the PHA and the mental health SIG, and then we'll hand over to Tony, who's going to talk for about 30 minutes, and we'll have an opportunity for some questions and answers from all of you. So just to let you know how this operates is that all of you are on mute, but there is a button, either depending whether you're on a Mac or on a PC, at the bottom or at the top of your screen, which says Q&A. So if you pop your questions in the Q&A, I'll be following those through Tony's presentation, and then we'll be picking up some of those questions at the end of his presentation. I wanted to start up by acknowledging that here at Deakin, we're meeting on the lands of the Wurundjeri people and the Kulin Nation, and we pay our respects to elders past, present, and emerging. And of course, we've just seen from all of you that many of you are in Victoria, but we've got people in other states as well. And I think something like 80 people registered for this seminar, so we may see more people come on from across Australia during the rest of the presentation. Clearly, there were people, Indigenous people and elders and experts from all across the country, and we pay our respects to them. I also want to acknowledge that today is World Mental Health Day. So it's super that we've running an event with the PHAA on this particular day. And I think it's important to acknowledge the value of lived experience and the value of so much of the work that people are doing in organizations and institutions already. And that this really is on the political agenda at the present time. I do some work with Beyond Blue and with some other organizations, and I haven't seen a time where mental health and these type of issues are so much up the front in a bipartisan fashion as well. Let me just go to my next slide. I've just got 3 slides, and I'm going to hand over to Tony. I wanted to say that the PHAA is a membership organization, obviously representing a public health perspective. We have about 1,700 members. You can join as an individual or as an organization. If you're a government body or an academic body, you can join as a member of the PHAA. The PHAA has several special interest groups, something like 15 different mental interest groups. And the mental health group is actually one of the larger ones. I think we have almost 200 members now. You can pay a little extra when you join per annum, and that allows you access to our forums and also to our policy development process and events such as this, I suppose, as well. In the last, with my colleague, Fiona Roberts, and also with the other members of the executive, we have been working with those 170 or so members to develop position papers. One very general one on mental health, one on mental health and work, which I'll talk about just a tiny bit because it's relevant to today. That is a position paper which was developed and last reviewed 2 years ago. So it's about to go into our review process where we'll be seeking input from members of the SIG, and then we'll be going out more widely later next year. We've just published a new and updated position on mental health and insurance, a key topic, and I know that that's quite a lot happening in that space at the present time. One on physical health and mental health, a new one on suicide prevention, and one which Fiona has been particularly involved and passionate about, which is youth mental health. So I encourage you to go to our website, have a look at those position papers, and I very much hope that you will find those useful in the work that you do. We'd very much like feedback on how we could make those more useful and how we could disseminate those. Let me just say a little bit about the topic today, which is work and mental health. This is the summary of the work and mental health position paper, which PHAA has from a couple of years ago. This is the current one. And as I said, we'll be looking to review this. In very general terms, I think this fits beautifully with what Tony is going to be talking about today. Just the summary, that the work is a key determinant of health. And I don't really want to say much more about it than that, but go to this document, give us some feedback on this, use this document if you can. And we very much look forward to hearing what you think about that in the future. So I'm going to pass over to Tony. Tony is the lead at the Center for Innovation and Health.
Determinants of health domain.
The Determinants of Health domain here at Deakin University. I've known him since he was at University of Melbourne. He actually taught me during my Masters of Public Health about 7 or 8 years ago. Yeah, so you forgot that. It's always great to have those mentors and those people that you follow through. I'm going to hand over to Tony. He's going to talk for about 30 minutes. I very much hope that you've got some engaging questions. We will record and publish the 30 minutes of his presentation, but I will say to you that we will not also put up the questions and that discussion that you may follow through with. That's really to encourage you to ask left field questions, some questions, but perhaps that you wouldn't feel comfortable with if they were shared in a more sort of public domain for posterity. So those questions which you ask, I ask you to be make them interesting questions, make them challenging questions, because there's a big question about what do we do next. So I'm going to hand over to you, Tony, and if you could take the share from here.
Okay, hi everyone. It's Tony here. We're just switching over the controls. Come on, video. Oh, no, it's still saying that the host has stopped it, Ian. Oh, that could do it there. Here we go. Start video. Oh, it's still not doing it. Oh,
okay.
Come on.
Yep.
Sorry, bear with us just a moment. Share screen to. Oh, it's still not working. Sorry, folks, we had this going just a moment ago.
I can do the slides if you just tell me when to change the slide.
Well, I need to see them in order to speak to them, though. So there's screen 2. Okay. All right. Thank you. All right. Sorry, everyone. Technologically challenged here. So welcome and thanks for beaming in today. So we're going to talk about work as a social determinant of mental health, and I'm going to give you a little bit of background to sort of set the context, and then go into my sort of 3-part argument basically about how work operates as a social determinant. So away we go. Now we can't use the regular controls for this, can we? How do I? Not working. Bugger. Sorry, folks. Oh boy. All right. It's going to be laborious. Yeah, they're not working. Now they're working. Odd, very odd. Okay, sorry. Hopefully no further glitches. So you're all probably aware that mental health problems are quite common among working people. Roughly 1 in 5 of us over a given year will experience a mental health problem, usually something mild, perhaps mild anxiety or mild depression, and about 5 out of 100 would experience more serious conditions such as major depression or schizophrenia. And this has lots of implications at lots of levels. For individuals, the potential for discrimination on the basis of having a mental health condition is very real. Being able to keep one's job or the job that one would prefer to have and avoid unemployment is another aspect. At the organizational level, most employers tend to turn their minds to productivity and organizational performance, quite important. But we'll talk about other things organizations could do as we get into things. At a societal level, the workers' compensation scheme has seen most injuries at work decline over the years. And in the last decade or two, what we're seeing is a single category that is rising is stress-related mental health claims. At the disability pension level, at sort of more societal level, disability pension schemes around the world, again, mental disorders is the rising category among all. Now, there's lots of law and policy in this area, and it's quite a lot to consider. The OH&S obligation to provide safe work extends from physical to psychological safety at work, and that's development here in Victoria and nationally, probably in the last roughly 15 years ago, that was added to the legislation. Anti-discrimination, equal opportunity, employment law, all of these things are relevant to psychosocial working conditions, which are a huge influence on mental health. And then disability employment is another aspect that intersects with this as well. So for the mindful employer, manager, worker, there's quite a lot to understand in the policy space. Determinants of health, we'll all be familiar with, living and working conditions there in the middle. And of course, with work, its absence when you want it is defined as unemployment. And we also know that unemployment is particularly bad for mental health, which we'll touch upon. But most of the talk here will focus on the working population at work. So this then, that's the little bit of background, and we'll launch now into my argument. And it goes like this, that work operates as a social determinant of mental health and well-being through different groups having different levels of exposure. That might be migrant workers having worse working conditions than Australian-born. It might be women experiencing lower conditions than others. Sorry, Ian's reaching in here to check something. What? Okay, I can keep talking. Sorry. Okay, good. All right. Sorry, there's something going wrong in the background. We'll start that slide over again. Sorry, my discussion of it. So different groups might experience different working conditions on the basis of attributes or on other things. And whatever the cause, differential exposures to working conditions that are harmful or beneficial can translate to differences in health. In addition, if a particular group is more sensitive to a given level of exposure, then that could compound a difference in exposure. And both of those factors can contribute to inequalities or inequities. Inequalities, obviously an objective notion, inequities more about fairness, and we tend to focus more on inequities in the policy space. And I have that final bubble at the bottom, really to not leave you just with the description of the problem, but at least a little bit on what can be done. So those are the parts. We'll unpack each of those now as we go forward. So work obviously can affect health for better and for worse. It's as beneficially, it can be direct and indirect effects. And I'll give you examples on the next slide. And then of course, lack of work when sought after unemployment also has negative impacts. There's not any good impacts there. To give you a few examples of both of those, income, so work as a major determinant of health is largely beneficial, mainly through income, because that's most people's primary determinant of adult socioeconomic status. And then, of course, opportunities to become better socialized, to develop identity, self-esteem, self-efficacy, opportunities for growth and development, and linking into other social networks beyond your neighborhood and family. Such as notions of bridging capital and so on, and a sense of belonging. All of these are powerful, positive determinants of mental health and well-being. On the negative side, there's can be direct effects psychologically, physically, and so on. For instance, noise is a hazard that increases the risk of adverse mental health, as well as psychosocial things such as exclusion. Indirectly, via health behaviors, if one works long hours and has lower physical activity, this can result in higher BMI or worse mental health. Many studies have shown that job stress is a barrier to smoking cessation. So various ways in which indirect effects could happen. And also we can even go to intergenerational sorts of examples, such as we have portrayed here in this cartoon version of sort of a contract cleaner. Let's assume this woman is precariously employed, saying to her boss, my meager income is putting my kids at greater risk of obesity, and what are you going to do about it? So this just speaks to the notion that disadvantage can be perpetuated between generations. In terms of psychosocial working conditions, the jargon I used just a moment ago, to unpack that and define it a little more clearly, it's the psycho refers to, obviously, mental, and social refers to the interaction between the person's psyche and his or her environment. There's a handful of psychosocial working conditions listed there that I hope would be intuitively graspable to everyone. Psychological demands at work can be the amount or the cognitive load, or whether it's emotional labor, such as caring, providing care for children or sick people. Job control is about how you get to decide to do your work. It might be control over your hours, control over the skills you use, the ability to use a variety of skills. Monotonous work, we know, is not good for mental health. Job security is another big one, and growing potentially with the growth of the gig economy. Social support at work is a powerful buffer against the effects of stressors, and something that promotes positive mental health and well-being in and of itself. So it's both has a double value, really. It's quite a potent modifiable factor in the workplace. Long working hours and underemployment are quite important. They are also linked to mental health, shift work, and harassment in its various forms: psychological, racial, physical. Sadly, there's numerous ones to list there. And then discrimination in the workplace setting is also, I would argue, a psychosocial working condition. So all of these are modifiable and quite widely linked to a huge range of ill mental health outcomes and disorders. This is just listing a few here. Generalized distress, burnout at work, which isn't a diagnosable condition, but is a mental health problem. Depression, anxiety symptoms or diagnoses, suicidal thoughts and behavior, and also the most recent epidemiology getting quite strong around suicide mortality as being linked to psychosocial working conditions. On the flip side, as well as these working conditions being associated with ill mental health, they also erode positive mental health. So mental ill health is on, if you can picture, you can't see my gesturing here in the corner, but if you can picture on one axis ill mental health, and then one coming in at a different angle on positive mental health. They're not the same thing, and it is possible, in fact, though not common, to be experiencing a mental illness yet still have flourishing or positive mental health. So it refers to emotional well-being, social, psychological functioning, and when one is in the optimal state of positive mental health, this is often referred to as flourishing by Corey Key's model and some others. Only a couple of studies to date have shown links to these well-being or positive mental health outcomes, and those have only been cross-sectional. So it's early days here, but it's a positive and a negative at the same time, because if in fact these conditions are more strongly linked to positive outcomes than negative, then it's all the more case for acting to change them. Okay, so now into so we know a little bit about working conditions. Now we're going to talk about how exposures vary by group, or differential exposures to working conditions. That's the first part of the core of the argument. Nancy Krieger talks about an inverse hazard law, and this is not restricted to the workplace setting, but in general. And as she articulates, the accumulation of health hazards tends to vary inversely with the power and resources of the populations affected. Many of you will have heard this argument in various forms before, even before Nancy Krieger articulated it. And this differential exposure, let's go through a handful of examples. Here's the exposure of unemployment. That top line is our 15 to 24-year-olds hovering around, 3 times the unemployment rate of the rest of the working population over the last several years, as one example. Here's another example of sexual harassment at work. This was from a survey I did some time ago. A simple measure, my job exposes me to unwanted sexual advances, 4 times higher among women than men, highest in the youngest age group, And compared to women, this is within women only, women in permanent versus precariously employed women were at 3 to 4 higher fold risks again, showing that, you know, that the particular vulnerability there of precariously employed workers who can be dismissed at will. That's quite an ugly picture from 10 years ago now, or the data is even older than that, but which is echoed down to the present. Unfortunately, we still have a long way to go there. But that's a very stark example of differential exposure. Here's one that I'll just talk you through. Sorry, it looks a bit busy up there, but this is, we set out to ask the question, well, we've been doing a little bit on trying to improve psychosocial working conditions at work on a policy level. And if we're succeeding, then we should see over time that differences are narrowing. So that first panel in the upper left, A, is just a measure of job control. And the dotted line above is men, and the dotted line below is women. And what I was hoping to see was a convergence or a narrowing of that difference in job control by gender. And it's going nowhere, sadly. So this is only up to 2008. Maybe with another 10 years, we might have seen that narrowing further. But interestingly, you can make that difference go away by controlling for form of employment, that is permanent versus casual versus temporary, self-employed and so on, by controlling for that, and occupational skill level. So in short, the difference in job control, and this is probably related also to the difference in pay inequity between men and women, is largely driven by a segmentation into lower status jobs. We won't talk through the whole slide here, but the second one on the right, panel B, you see the age group that's sitting out there in terms of job control is our youngest workers, 15 to 24 at the very bottom. Now, this is an example of something that is in theory modifiable, but when a young person enters the job market, really they arrive with little experience, and that's therefore it's a bit inevitable that low job control would be the lot of workers in their early years in the labor market. And that can be addressed by things like moderating demands and providing good support to young workers. So that's enough on that example. Job strain is the combination of low control at work with high demands. And this is particularly stressful as theorized and then borne out by empirical studies. For example, job strain exposure nearly doubles the risk of depression. And as you might guess from the previous slide, women being more likely to be exposed to low control at work than men, that job strain is also a more common exposure for women than men, 26 versus 19%. And there's similar differentials in other developed countries around the world. Now, knowing the prevalence of an exposure and combining that with the increase in risk in a given outcome allows us to calculate population attributable risks. And we've done that. And what we see is that by job strain alone for depression, attributable depression, men would be around 13%, women around 17%, which is quite a lot, really. And there's obviously a differential burden there between men and women. And some other investigators have derived similar estimates in other parts of the world, a French example there. And now this obviously is an example of an inequitably distributed problem. And if we were to consider all psychosocial working conditions, insecurity, bullying, harassment, and other forms, computer restart required. No, we won't be doing that. Sorry about that. This would translate to larger inequalities and starkly, large burdens that are preventable. So other examples you could think of to close this segment of the talk: lower pay for equal work, high rates of underemployment among workers with disabilities. Migrant workers we know are disproportionately employed in dangerous, dirty, and demeaning work. And there are many more examples. So much work to be done in addressing differential exposures. This is just to identify some of the possible determinants of exposure and opportunities to work. And obviously, the more of these that convey a disadvantage in terms of the quality of work probably the worse off that individual will be. Convergence of determinants would increase risk further. So that's it for the moment on differential exposure. And now what if a given exposure, say low control, is even more impactful for one group versus another? That's what we're talking about now. So differential impact is on top of differential exposure. What are the factors by which these associations might differ in magnitude? Those could include gender, ethnicity, age, disability status, and more. Here's one example. This is looking at the HILDA study, which some of you might be aware of, the Household Income and Labor Dynamics in Australia study. It's now going 19 years and annual waves of data are collected. We were able to identify participants who were working and had a disability for at least 2 years of working in a row, and then experienced an onset of unemployment. And what we had hypothesized was that unemployment would be more harmful to the mental health of a person working with disability. And that's in fact what we found, a few times higher impact. It's a couple of points on the mental health inventory score scale, which is not at a clinically significant level, but it is a significantly greater impact. And it's likely explained by the fact that attaining work of equal quality and conditions for a person with disability is a lot harder than for a person without, and that is a likely explanation for that differential impact of unemployment. Here's an example of job stressor exposure and suicide by gender, completed suicide, from a national study using the National Coroner's Information Service and estimating exposure based on occupational title. And what we find is that for men who tend to identify more strongly with work than women, although that situation is changing, both high job demands and low job control were associated with a modest elevation in risk of about 40%. So an odds ratio of 1 would mean the risk is equal between the two groups. And then among women, interestingly, it was either low control was not associated, and high job demands, surprisingly to us investigators, was associated with a protective lower risk of suicide for women. And we weren't able to fully control for all possible confounders in this analysis because we were working off death register data. But that's something that's been replicated and warrants further study down the track. It may well be that some aspects of high job demand is linked in with more challenging jobs or more stimulating jobs, and it's unclear. An interesting puzzle, a positive finding to unravel as opposed to a negative one for a change. Okay, another another example, looking at job control and depressive symptoms. We know that young people with a history of mental illness in adolescence are less likely to complete school, less likely to find employment, and less likely to be, or more likely to be in the NEET category, not in education, employment, or training. But many young people with a history of mental illness do in fact gain employment. And the question here is, when they do, are they differentially sensitive to the effects, to the exposure of low job control? And the answer is yes, about 3 times more sensitive. And what the value of this is in considering job design for young people with a history of depression, and this can be integrated into programs such as individual placement and support, and also informing disability employment policy, for examples. Here's another example of looking at unemployment and mortality by gender. And you see on the left, the darker bar is for males, on the right for females, a much stronger effect for males, which is not explained by this study, but the prevailing wisdom is this is largely about male identity being more tightly aligned with employment and occupational status than it is for women, at least historically. So that was our whirlwind sort of argument of how work can operate as a social determinant of mental health, and illustrations of particular examples to flesh that out for you. And now just a couple of words on what can be done so as not to leave you completely in despair. Sorry, that's exaggerating to make a point. So this is our approach to workplace mental health, and this arose out of many years of going into workplaces and having way too much to say. And we challenged ourselves to distill it down to its very essence in terms of what we would like people to do to improve the role or the influence of work on mental health. And that would be to prevent harm and to promote the positive aspects of work, and to respond when mental health problems manifest in the work context. And one might, how to do this is a much larger question than what to do. This answers the question of what to do at a high level. And programs in a given workplace might be doing one activity in each of those things, or doing layers and layers of activities in a mature program. Going further, and this is another talk that I do, maybe one day we'll do that one for PHAA, but this is just to say that there are things to do, and this is an evidence-informed approach and principles-based, and that we're out there trying to make this happen in some workplaces. WorkSafe Victoria's WorkWell program was based on this model. That's a $50 million investment by WorkSafe, including a fund where workplaces can go and apply to run, develop, and implement workplace mental health programs across Victoria. I've said all that. We'll skip that one. As in any public health approach, what one does to prevent harm, promote positive, or respond also intersects with intervening at multiple levels: source-based prevention versus individual, or making people more resilient. There's a role for that. That's secondary intervention, make people better able to withstand stressors. And tertiary is responding to problems, and enough said on that one. But there's intersection of traditional public health approaches with the integrated approach that I've just described. So just summing up then, work can operate as a social determinant of mental health and well-being through differential exposure to working conditions, and that can be coupled with differential impacts to contribute to and produce mental health inequalities and inequities that we can address given the political will. And there'll probably be some questions or comments about that. There's a lot of work to do in that space, but the positive news is there is some things happening. This is a more detailed picture of the story. In short, the arrows pointing directly at the boxes would be determinants of exposure, and the arrows on the bottom pointing up, or bottom and top pointing up to the arrow, the relationships between variables are effect modifiers. So those of you epidemiologists, differential exposure is just a direct influence, and oops, what happened there? I was doing an automatic shift. And the relationships between exposures and outcomes is effect modification, which is differential vulnerability. And as I've said, that we do have some successes. Workplace mental health has achieved, there's a lot of attention to it in the last 10 to 15 years, in particular in Australia. Beyond Blue's program, workplace program, was launched in 2004, I believe. And there's been a lot of good work in that space, but there is still a very large burden of work-related ill mental health, and we have a long way to go. Thanks. Oh, I'd like to dedicate this talk to Allison, who died rather sadly, sorry, a couple of months ago. Allison's name you saw on many of those papers above. We worked closely together for many years. She was struck by a tree falling while she walked through Princess Park, left us way too soon. This one's for her.
Tony, thank you so much, and about the sad end to your talk there. I had a couple of questions I wanted to kick off with, and please, if you put in the Q&A box rather than the chat, if you can, any questions that you have, I can put them then to Tony. I can see we've got a couple of thanks already. Someone is asking, will the presentation be available? Yes, the presentation will be made available probably in the coming hours. The question I had one sort of public health question to start out with, Tony, because not everyone has an MPH, and you talked about population attributable risk, and there was that figure of 17%. What does that mean? Can you put that in other terms, what that actually means, that we can, as a take-home message for us?
Yeah, sorry, I should have said more about that. What that means is that in theory, if job strain were eliminated as a risk factor, prevalent depression would come down by that percent.
And that figure was much higher in Australia, from what I could see, than it was in...
No, well, let's flick back to it. Hang on a sec. Oh, does it want to flick back? Oh
Okay.
Boy, it's very slow.
Okay.
Oh,
so
it's not going.
It was
no,
higher
it's similar.
or lower?
They were similar. They're similar estimates.
Okay.
Yeah.
I won't overinterpret that. So the other question I had was the gig economy. This is an area that I've seen in a couple of respects, and I guess it could work in, and I'm asking you to speculate a bit, but based upon the evidence that you have, is in one respect, the gig economy and the digital economy is trying to automate those mundane, boring tasks in our work, and to use artificial intelligence to do all of that, and possibly that would have a positive mental health benefit, and that we were doing more interesting things with our work. But I can also see in the gig economy, in the digital economy, the transformation that we keep on talking about of all of our roles, the casualization, that could be quite destructive. How do you see this playing out? And seeing as this is a cause of a cause, this is at the very top, this could be quite significant, surely.
Yeah, well, that's a small question.
Good.
So the first part was about how automation and so on could be positive. Yeah, well, that's true. I'm getting a terrible echo here. I'm not sure if you guys are too. Oh, is that? Oh, okay. Sorry for the distraction. So that is certainly true, and automation has been entering the workplace and the rest of our lives gradually over a long period of time, of course. So a lot of the analyses there that are up on the screen, when I started training, there were still punch cards and things you had to do, and a lot of calculations by hand, and now we do that all by stats packages, and that's automation as an example. So it is coming on, and that has allowed us to do more, probably to do too much in our work. Job intensification is a phenomenon all across the working world, from the low skilled to the high skilled. But what is the flipping over to the gig economy? Interestingly, when one looks at the ABS labor force survey data, the percent of casualized workers, we have one of the highest percentages in the OECD at around 20–25%. And that has leveled off, surprisingly, over the last 10 or 15 years. And it's remaining fairly stable. What is changing is within the self-employed proportion of the population, which is about 15%. And it's about half own account self-employed workers and half self-employed people employing others, or your entrepreneurs, your small business owners, for example. And what you see is the own account, the sole self-employed, growing. And these are, for example, would be a journalist who no longer is on staff at a newspaper, for example, but is now working by the word or by the story as a contractor. This could be your pizza delivery man or woman, and so on. And that, of course, those workers in those sectors where major structural changes happened, of course, the mental health impacts are probably particularly acute. There have been many studies of, for instance, auto industry towns around Adelaide and others, like decade-long studies showing the effects. And you have winners and losers, but on average, there's a net impact on the health of those communities, to be sure. Flipping to another aspect of the gig economy. One can see this too from a sort of a political economy perspective of what's happening is the risks of doing business are being transferred from the business itself to the worker. So traditionally, companies had to plan for variation in demand, for example, for their service or product, and workers would be kept on during that time, at least the white male heterosexual workers. Well, obviously, a lot of people were marginalized in the labor market historically, but with casualization, that's a way of saying to the worker, we'll only call you when we need you. I mean, many of us will have children who are told they go to work and the next day, and when they come home, you ask how it went, and are you working tomorrow? Well, I don't know. They'll call me in the morning. So
Yeah.
this, oh, sorry, you're calling me. Yeah.
Yeah, so we've had a question which relates, I think, to what you're talking about from Liz Reddy. And she says, how can we protect vulnerable groups, migrant workers, people working casually, cash in hand? Or is it about empowering these people not to accept poor work conditions? So I guess what she's saying is, should we empower people not to have to be in this situation? And what does that mean?
Okay, so the answer to that is certainly both. So all the empowerment in the world without government that won't back up the rights that we're supposed to have isn't going to really work in the end. And if people don't speak up, people are rarely offered something they haven't asked for that somebody could get away with not giving you. So both are critically important. And as to how to protect vulnerable workers, boy, you know, advocacy, we have laws on the book that say people shouldn't be harmed by their work. Those laws were only extended 15 years ago to psychological health, which is a significant achievement. But the vast majority, those figures for job strain attributable depression, I was able to take those numbers and compare them to the number of stress-related claims that get compensated. And it's about, I don't know, as an order of magnitude or more less. So most work-related ill mental health is not compensated through workers' compensation, and there are a variety of reasons for that, many of which are the system is not working, but also many people who do know their rights choose not to claim because of persisting stigma around mental illness, and knowing that even though it's supposed to be confidential information, they might be asked in an interview if they've ever filed a stress-related workers' comp claim, which they're not supposed to ask you, but they might anyway. And so this is an example of, if you will, you know, a positive change, but we're still in the process of normalizing that change. In the face of all of this, what we have is, you know, how do I cut to the chase? Neoliberalism is one at the moment, and the general rule is more with less. Every job, I imagine most of you on the line could probably relate to seeing your workload go up over the years. It certainly has for me. And at the same time, the resources provided to you to get it done probably have dwindled. This again, I have experienced, and I imagine many of you. So as a colleague of mine in organizational development says, I can summarize all of the latest management theories for you in 3 words: more with less. And people feel it. So this is the elephant in the room. While at the one hand, we have great policy interests, we have a nationally funded Beyond Blue initiative in the workplace and a lot of other good work happening in the workplace, but disproportionately, the responses that we see are individual directed, build your resilience and so on. Very little intervention effort directed at improving the quality of work. And if we don't improve the quality of work, we'll continue to see, you know, work-related mental health burdens rise.
I'm going to encourage you, if you've got a question, to put a question in. I've got a related question to that, and we've probably got about another 5 minutes. Mine was, I saw there's some data out quite recently on what was cost effective in mental health prevention. And one of the things that scored quite low down the list was actually providing something like a, I think it's called a employment management system, those management systems where someone can contact if they're in distress. And
Oh, employee assistance
employee
programs.
assistance, sorry, I
Yes,
couldn't
yes.
find the words for
Yep,
that.
yep.
But there's employee assistance programs. Yes, we all know that we have them. We're encouraged to have them in our workplace. But from a cost effectiveness point of view, they're really, someone's already got the problem by that point.
Mm-hmm.
And that's where we put so much of our efforts. And so what's your reflection on the type of efforts that we're putting into managing and to treating mental health conditions, and how that money could be better spent, and some of those interventions, how we need to shift that to further up to the social determinants, which is what you're talking about? How do we do that?
Oh boy, I wish I had the answer. Well, in studies I've done, interviewing employers, qualitative studies, for example, asking, well, what do you do about job stress, workplace mental health? Oh, we have an EAP, we have an employee assistance program, and sometimes, not always, that's viewed as the response, which is obviously reactive. It's at sort of the far end of the integrated approach. Not to knock employee assistance programs, it's a valuable thing to have available if and when one needs it, but by no means is it a sole answer to workplace mental health. Most of what people do in the workplace space around mental health is reactive, and that's just because it's a damage control response, and the notion of getting people upstream is really requires a long-term view from an employer, and increasingly business and capital is on a short-term view, which is, what can I get for returns tomorrow? So the social contract of work has certainly eroded over time, where once, at least for certain segments of the population, not for everyone, truly, but there was a social contract of work wherein if you did well by your employer was obliged to do well by you, and it was a long-term relationship. That is no longer the case, and so reaction is mandated when one is faced with a problem, but prevention you can ignore, because it won't manifest under your watch as an employer. So we have perverse incentives, really, because people shift jobs so much, and because the responsibility can fall outside an employer's perceived mandate. That's to some extent what happens, unfortunately.
Not wanting to just leave us on a positive note, but I think it's, I wonder, where do you think that the levers of change might be? And where have you seen projects, because you've worked across all sorts of fields, where do you see levers of change that could make a significant difference, that could really take us to that next level? We've got quite a bit of interest, quite a lot of discussion with the Productivity Commission, with the Royal Commission into Mental Health in Victoria at the present time. Yeah. What do you think would be, if this happened, this could make a really big difference to mental health in the workplace?
Well, I mean, the place that you see the best things happening and the highest receptivity to looking at the work itself, not just the worker or just responding to illness or making workers more resilient, is where you have high value employees, or you have high social status employees, such as emergency responders. So there's been a huge initiative by Beyond Blue and across the sector, more broadly by many actors, to try to address the clear and substantial problems of mental health for emergency responders. I have to say that most of that response has been at the reactive end. And there needed to be work there, so don't get me wrong, it's not that that should not happen. Relatively little on promoting the positive, and that's okay, that's not mandatory. It's a good idea, but it's not mandatory or legislated. And relatively little on improving the quality of work. Some employers are, like Tony Walker at Ambulance Victoria, he speaks very well and speaks about improving working conditions and the need to be doing that. And I've heard him say that he knew he was doing something right when stress-related claims were rising. That's an insightful comment, that he knew that should be happening. So that meant stigma was coming down. It was okay for people to come forward who were already harmed and to start, trying to get into a better place. So in a context where there's public mandate, visibility, consensus that we should actually make the work more doable, that's our best option. And thus far, so I ran a cluster randomized trial in Victoria Police that was a several-year-long project, started with a co-design phase to do, not to try to change the world fundamentally, but to do some important things that were achievable and feasible for Victoria Police, incremental change, but nonetheless. And we coupled management training for supportive leadership. This was the station commanders at police stations, sergeants and senior sergeants. That's where most of our intervention energy went, to try to improve social support and psychosocial working conditions for the troops. And then we did mental health literacy training for the troops themselves. What we found was that Victoria Police wasn't able to deliver what they promised to deliver. Less than half the troops received even the minimal 2-hour training. Less than half the managers received mental health training, and less than half the managers enrolled in the supportive leadership coaching program. So we had an implementation failure and no impact, very sadly. In another study up in the ACT with Claire Sean, who was then the leader of Beyond Blue's workplace program, we took an integrated approach to intervention, and this was late 2000s. Over 1 year, we saw, this was an uncontrolled study, we saw significant improvements in mental health literacy and no change in psychosocial stressors. This was the year the GFC landed. So, you know, the larger forces are the elephant in the room in terms of improving the quality of work. That's still not the conversation, even though we know from evidence and principles that that must happen if we're to really fix the problem.
Is that your take-home message? Is there anything else that you wanted to say as a take-home message to people?
Oh boy. Well, you know, despite hearing a lot of, you know, critical shortcomings, I continue to try to do this work because I think the argument is right, and it's no less challenging than you know, climate change and other things, and no less important. So we keep at it.
Professor Tony LaMontagne, thank you so much for your presentation today. Everybody stayed on the line, so I think everyone's been really enjoying your presentation and much appreciated. And we'll be back with another webinar from the Mental Health SIG at a future time. If you've got any feedback on this seminar, please do mail it through to us. I will send out the slides in the coming day or so. And thank you so much, and have a great mental health day.